Hello and Happy New Year to everyone. As you know, the evaluation and management codes for 2021 are going to be documented and accounted for in a completely different manner. We've done several videos about that, but there are some major updates that happened in the month of December, and I wanted to talk to you about them. In addition, some questions have arisen, and some people ask me questions that I think are important, so I wanted to answer them here today. Let's begin. If you want to know some of the practical, most important steps to do and things to remember going forwards, here they are. Number one, you need to focus on the medical decision making, knowing what elements qualify for medical decision making levels 3, 4, and 5, and what qualifies for a time documentation for level 5. Number two is you want to also focus on your efficiency by trying to cut back any time that you waste on HPI, review of system, or exam in the chart. Instead, focus more on the assessment and plan section of the chart and try to implement or try to put there all the elements that you need to get the code that you deserve by medical decision making. Number three is you may want to consider making changes to your workflow if you anticipate billing by time for a lot of your patients, because as we will see, one of the things that is going to be important is the concept of total time, where the time that you spend on the day of the visit on anything pertaining to that particular visit is what counts towards your time documentation. So you cannot do it the next day, for example. You have to do it the same day of the visit, and that might require some change to your workflow. Now, having said that, let's go ahead and talk about the updates and the questions that we received one by one. First, let's talk about the updates, and many things changed in the month of December. To understand better what happened in December, what changes happened, I just want us to take a step back and look at what exactly caused us to be here in the first place. Why did the AMA want to make changes to documentation in the first place? So the AMA intent, and you'll forgive me because I'm reading a little bit in between the lines here, but it seems that their intent was to strengthen the chronic disease management and preventative health care to try and help the population health. And the way they thought to do that is by empowering physicians and APPs and rewarding them for the cognitive work they are doing in clinic. They thought of four main ideas to help with that. Number one is to focus on the medical decision making. So you don't need to do an ear exam, for example, if you're seeing somebody for cardiovascular disease and so on. Some of the documentation was a bit, requirements was a bit archaic, was a bit outdated, so they want to modernize, if you will, the codes. Number two is they provided for an increased RVU compensation for different evaluation and management codes compared to previously. Number three is the reimbursement for prolonged visit. As you know, in the setting of primary care and chronic care management, a lot of times the visits take longer, and so they wanted a way to reward physicians and APPs for doing that work. And finally, they wanted to add a chronic care code, which is also called a primary care code, but that chronic care code was supposed again to reward physicians and APPs for taking care of a sick population. Now, what is the end result that came out after all this year 2020 of discussions and back and forth between AMA, the CMS, which is the Center of Medicare Services, and finally the Congress? Here is what happened. Some of the things that the AMA suggested survived December, and some of the things did not survive December. So the focus on MDM is still the same, and that does not change. The increased RVUs for clinic visits and E&M codes, that's still the same. Now, reimbursement for prolonged visits, that actually is on life support right now. So some of the elements of that idea about reimbursing prolonged visit in a different way survived, made it, but many things did not make it. So we'll talk more about that in the next slide. And finally, the idea about the primary care code or chronic care code that did not survive, that did not make it through December. So CMS Final Rule, which came in the beginning of December 2020 and was a big document, 2,200 pages, and had a lot of things. But one of the most important things for us was that they changed the prolonged code, how it's going to be used and accounted for as of the beginning of this year. Basically, what AMA had suggested is that after you are done with a level 5 requirement, for example, whether that level 5 was a new patient or an established patient, that every 15 minutes beyond that, you would get a 99417 extended visit code. Medicare objected to that, or Center Medicare Medicaid Services objected to that. The reason they objected to that is they said, imagine Dr. Peter here on the left upper hand corner seeing a patient for 74 minutes as a new patient visit. He gets a level 5 based on that. Now, if Dr. Paul sees the patient for 75 minutes, so one more minute than Dr. Peter, he gets 99417, an extended visit code in addition to level 5. For Medicare, for Central Medicare Services, that did not sound fair because for 1 minute you shouldn't get an extended code that gives you a lot of RVUs. So instead, what they decided to do is to change the way that the codes are accounted for, and basically you have to get 30 minutes beyond the minimum for any level 5 in order to get that extended code. For example, new time documentation would need to be between 60 to 89 minutes for level 5 in order to get a level 5 plus extended visit code. You need to do 90 minutes for a new patient or 70 minutes for an established visit. Now that basically takes it back to what it used to be. By the way, the extended level codes have been present for a long time. They are not anything new, but they weren't used. And the reason that they weren't used is because meeting that requirement is very, very hard. To get 30 minutes beyond the level 5, that requires a lot of time. That is very rarely happens in clinical practice. 15 minutes would have made a big change because it would have made it much more applicable and usable. But CMS is taking us back to the way that the prolonged codes have always been documented, and they are calling now them G2212. Now, the total time requirement is still the same, which means that instead of you having to say it's a face-to-face encounter with a patient with 50% or more of the time spent in patient counseling and coordination of care, you now take into account the total time spent, which is anything spent in preparation, in review, in seeing the patient, in even documentation after the visit, goes into that total time concept. But that's the only part of the prolonged code that made it. All the rest in terms of requirements for actual time spent was basically canceled or returned to the old method of accounting for prolonged codes. Just they called it G2212 instead of it used to be 99354 and 55 and so on. Next. Now, the chronic care code. The chronic care code will not be applicable for the next 3 years. That's not the doing of CMS, actually. That is the doing of the Congress. On December 21st, Congress passed an omnibus bill that included delaying the implementation of the chronic care code, the G2211 as CMS had called it, for 3 years. They are not going to pay for any of those chronic care codes for the next 3 years at least. The bill was signed by the president on December 27, so it is now the law of the land. I hope this makes sense so far and the updates make sense to you. But now we get to the second part of this presentation, which is the questions and answers. One important question that I've heard was what happens to 99201 and 99211? And I need to be clear on this because I was not clear in my very first presentation because the codes are not frequently used, but we need to understand what is happening to them and what to do with them. So 99201 is no longer in existence. It's not going to be used anymore, which is a new patient level 1. And the reason that it's not going to be in existence, which we understood when the final rule came out by CMS, is that the requirements basically for it would be exactly the same requirements as for 99202. So you really can't distinguish it from 99202 and therefore should be eliminated. 99211, the established visit level 1, is still in existence. Now it doesn't need any medical decision making simply because it is not even done by the physician. An example of this would be a blood pressure check. You, as a physician, you have your patient come for a blood pressure check. You want to make sure that the blood pressure is under good control. Your staff does the blood pressure measurement. Obviously you are in clinic, so it's under your supervision, but you don't have to see the patient. You don't have to spend time in documentation and in medical decision making. That is the 99211. I hope that makes sense. Now, another question is what happens to 99202 and 99212? When should they be used and will they be used at all? Is there any situation in which those codes would be used? So the answer is yes, they can be used in certain situations. It's just that the situation for them to be used is kind of rare. 99202 is a level 2 straightforward new patient visit that lasts less than 30 minutes. And 99212 is an established visit level 2 that lasts less than 20 minutes from start to finish. And the way that they explained it in the AMA presentation is it's basically for patients who could have been managed at home if they just looked at some the internet or some basic website for first aid or something of that nature and may not have needed to even come to the office. An example would be somebody with a skin lesion and they think it's something worrisome or are afraid that it might be cancerous, but it may be a skin tag or something very simple that the physician just looks at it and says, okay, it's a skin tag, it's nothing to worry about. And that is a level 2. Now that patient doesn't have any chronic diseases or chronic illnesses that are addressed at that visit. It's simply for that lesion that was seen and found to be something very simple, straightforward. So that's an example. Now remember, for that to happen, you need one minor problem, no analysis required, and the risk is minimal. And you need also for time documentation to be less than 30 minutes for a new patient or less than 20 minutes for an established visit. If that same visit, the patient was so worried, so anxious about this lesion that it took a lot of explanation, a lot of talking, a lot of review, a lot of discussion in order for the patient to be finally reassured, and the visit took more than 30 minutes a new patient or more than 20 minutes established total time, then it becomes a level 3. It doesn't become a level 2. I hope that makes sense. Next question: what happens to Medicare wellness codes, office consultation codes, and inpatient codes? The simple answer is they stay as they are. They are not changed in any way by this new code change that starts from the beginning of this year. Now, why is that? Well, CMS did not address the office consultation codes because it had stopped acknowledging them in the first place. Office consultation codes are used by specialists, whether it be medical specialists or surgical specialists, when they see patients. A number of years ago, CMS had decided that it will no longer acknowledge the consultation of a patient. It will just be either new patient or established patient. It doesn't matter if the primary care referred the patient to you or the patient on their own decided to start seeing you. It doesn't matter if you're a specialist or if you are a primary care physician in the eyes of CMS. All that matters is this patient new to you? And the definition of new is somebody who has not seen you in the last 3 years, or is it somebody who is an established patient who basically has seen you or one of the colleagues in your practice in the last 3 years? That is the definition for them, and that is why the consultation codes, Medicare did not touch them, and the AMA is just saying that the changes are going to happen to the new and to the established patients, not to the consultation. Same thing for inpatient care. None of the changes we discussed addresses at all inpatient care, which means that for office consultation notes and codes and for inpatient codes, the way that we account for them stays the same. The old rules for the note, for the time, you have to still put in, if you're billing by time, you still have to put in the time was face-to-face, and more than 50% of the time was spent in patient counseling and coordination of care, with the same classic use of the prolonged codes, same everything, as if 2020 hadn't happened to basically to those codes. Now, commercial insurances have not responded yet to those changes, and when they do, there may be more updates and maybe more things for us to discuss, but we will cross that bridge when we get to it. Now, for the sake of anybody who just wants to pause the video and take a picture of this or just read the requirements here for the office consultation and inpatient consultation, what time documentation is needed, I have this slide for you. Next. There is a question here about the medical decision making. Who can use the independent interpretation of test clause in medical decision making, and on which study can it be used? So the independent interpretation of study or of result can be used on any study amenable to direct interpretation. Anything where you can look at an image or a graph or some raw study material that to make your own conclusion about the study. It can be X-ray, ultrasound, CT, MRI, echo, EKG, continuous glucose monitor, charts and or graphs, sleep study, raw results, but not lab result. Now, it can be used by any physician or by any APP, regardless of who ordered the test in the first place. So, for example, you are an APP, you didn't order the study, some other physician ordered an MRI on this patient. And it was interpreted and a report was read by a radiologist. But the patient now is seeing you in clinic. You get the pictures, and you're looking at those images, not the report, the images, and you are making your own conclusion based on the images that you are seeing and your interpretation of them. That qualifies you for independent interpretation of a test. Now, it must be direct visualization of the study, not by reading the report, but that's it. Regardless of who ordered it, of who is the patient, the physician of record for the patient, your relationship to the study is what matters, and your direct visualization of the image is what matters. All right, another question about time documentation. Can chart work performed on the morning after the visit be included in the time documentation? And the simple answer is no. The simple answer is no, because for time documentation, work must be done on day of service, not within 24 hours of service. So if you're seeing the patient on December the 6th, for example, then you have until midnight on December the 6th to complete every and all things that go into the time documentation requirements for that visit. It cannot be December 7 in the morning. You come, even though it is within 24 hours of the visit, but it's not, it doesn't qualify. According to the letter of the law, it doesn't qualify. Now, that is why I was telling you, you might need to make changes to your workflow, because if you are in the habit of seeing patients and then the next morning you come early and dictate or finish all the notes on them, now you can still do that, but you cannot do it for time documentation. The time that you spend doing that does not go into the total time for the visit. Now, if you are doing it by MDM, well, it doesn't matter, but it's if you are planning on doing some at least of those visits by time coding, you need to make sure that they are done on the day of service and that the notes are locked by the end of the day. Consider changing your workflow to adapt to those requirements. Now, again, where do we go from here? I go back to that basic slide that says 3 things you need to do. Know your codes. Number 2 is efficiency is very important. Focus on your assessment and plan section of the chart. Cut back all the time that you spend in other sections. Cut back all the duplication, and be short and direct and targeted in your documentation. And number 3 is consider workflow changes. I'll let you know if we get any other changes. Hopefully not, because we're all tired of this. But happy documentation. Look at the big picture. It's going to be better in terms of revenue for the clinic work. It's going to be more rewarding for the cognitive work that you invest and you have invested your time in. So hopefully it's going to be good. And with that, I'll leave you. Have a happy new year.